Good evening, everybody, or good morning, wherever you are. Greetings for the day. Welcome to this webinar, which is being jointly co-hosted by the Harvard University and the Public Health Foundation of India, with participation of the faculty also from the All India Institute of Medical Sciences, New Delhi. The Harvard University, especially catalyzed by the School of Medicine, has brought together stellar faculty from Harvard and in collaboration with PHFI is addressing some of the very important issues related to COVID diagnosis and surveillance in this initial webinar. We will be following it up with a webinar on treatment, which will be webcast on the 21st of July. And we'll probably follow up with other webinars as well, elaborating on some of the themes related to COVID. Our first speaker for the day is Professor Pardis Sabeti, who is professor at the Center for Systems Biology and Evolutionary Biology at Harvard University and in the Department of Immunology and Infections at the Harvard School of Public Health. She is a member of the Broad Institute of Harvard and MIT. She is a computational geneticist who has investigated Ebola and Lassa hemorrhagic fever among a host of microbes that have captured her scientific interest. She is a highly awarded scientist who featured in the Times Person of the Year list of Ebola research. She has been working on a large number of microbes, but apart from microbes, she is also the lead singer and co-songwriter of the rock band 1000 Days. So microbes and music, a great combination. Go ahead, Professor Sabeti.
Thank you so much, Dr. Reddy, for that lovely introduction and yeah, unconventional end, but thank you. I'm really excited to be talking to you all today. I'm gonna start my slide share right here. Host disabled attendee screen sharing. Can someone enable screen sharing? Try that again. No.
Go ahead.
Yep, great. Thank you. Okay. Yeah, so I'm going to be talking today about how we can leverage both diagnostic and information technologies in the COVID response. And as Dr. Reddy said, I have been studying a number of different viruses, deadly viruses like Ebola and Lassa, Zika and other, and devastating viruses like Zika and others. I'm actually going to start by just telling you a little bit of a story about mumps. And sort of an outbreak much closer to home. There's a mumps epidemic in 2016 that started at Harvard University. And it was just an interesting phenomenon and important to think about when we think about reentry and these respiratory viruses. I was on the Outbreak Surveillance Committee and we started seeing infections on the sports teams, in the residences, in the dining hall. The public health team was tracking them to their health services where staff were infected there, a commencement event that later appeared to, that later we learned through genomic information seeded an outbreak possibly in East Boston. And we're able to trace that back. And just importantly, when we try to think about what is going on in these, when we do traditional epidemiology, when we try to understand how are these infections spreading, it's a painstaking process that's done manually, phone calls and trying to track back and understand. And the public health teams at Harvard and the Department of Health in Massachusetts worked very, very hard to uncover a number of transmission links between different individuals. But respiratory viruses, as you know, move very, very quickly. Oops. And when we overlay the genomic information, when we sequence the virus and we're able to see the links, because the sequence of a virus is essentially like a barcode that's slowly ticking away and changing over time, allows us to track kind of that passage of time in those transmission events. What we saw is that all of the transmission links epidemiology found were actually very accurate. So it's a very accurate practice, but that it was very underpowered because we missed a lot. And so we recognize that in these fast moving events, if we really want to understand what's going on and know how to respond, we're going to need new tools such as mobile applications. And at that point, my lab started working on those as well. Fundamentally, though, over all the work that we've been doing, we've had this sense that, as many do now, the importance of being able to detect viruses, but anywhere they occur, from point of care, in rural clinics, faraway sites, or at home where possible, since coming into the hospital will only create more transmission events. But to be able to do more deep diagnosis in hospital settings, track viral load and differentiate from other viruses, and then to have sequencing capacity to uncover new viruses and to further understand the ones we're tracking. We also want to be able to connect that information in real time across a grid to make sure that all of these information systems are leading in. I'm going to close the door because my son could pop in at any moment. 1 second, I apologize. I hear him raging out there. Let's see, so, to connect that information in real time, to then get individuals to come to attention, to somehow let us know that they're, they might be sick or they may be infected and of some sort, and then to empower every actor in the system to make sure that everyone has the best information and best background and knowledge to act. So when we think about detect, for the vast majority of viruses that we worry about, including SARS-CoV-2, we've seen them before in some fashion. SARS in 2002, MERS shortly after, and we've known viruses like Zika since 1947 or Ebola since 1976. So we have their genome sequences. We could be developing diagnostics. During the Ebola outbreak, our collaborators in Sierra Leone detected the first confirmed case in the country just by using PCR with the known genomic sequence. These capabilities are possible, and that we can be leveraging point of care tests like PCR to be ready for any virus that emerges. And we could have, as soon as the SARS-CoV-2's genome was sequenced, we could have across the globe have been having surveillance diagnostic capacity ready. But we even need newer diagnostics for infectious disease. Zika made that really abundantly clear how difficult it was and how important it was to get this information. We need field deployable, inexpensive, fast, rapidly programmable tests. And a lot of those have a potential to be transformed through a new technology called CRISPR. CRISPR is a bacteria's immune system to viruses and are ways of detecting and destroying viruses. Now, one thing I just want to note is I have a conflict of interest, multiple conflicts of interest in diagnostic space, because I'm also moving many of these technologies through commercial use and throughput. I'm a founder of a company called Surveillanc Biosciences that is based on this CRISPR technology, and I'm a board member of Danaher Corporation that owns Cepheid and Gene Expert and IDT. But so take anything I say with a grain of salt. I just want to tell you about these kinds of technologies. Essentially what CRISPR is it's a RNA guide that can detect a particular sequence, pull down a protein that then can cut that sequence, and we can pair that with a fluorescent readout that will happen. The readout will be signaled if a cut happens. And that can really move us to these point of care tests. We've developed one such CRISPR Cas13 tool called SHINE that can use nasal swabs, and we've been showing it works in saliva, can go on a 1-through system where at the moment all we need is a heat block, but can actually get to the point where we can do it at room temperature as well, and we see evidence of that. So this is a technology that could make that easy programmability of PCR, but the deployability of something closer to a lateral flow strip test. We've also been able to massively multiplex these tests. This is showing you 170 viruses known to infect humans against 170 guides, and showing a high amount of sensitivity and specificity on synthetic guides as well as in clinical samples. And that same sensitivity and specificity remains even when we're trying to target very specific strains of a virus, like all the different flu strains, both on also on clinical samples, working very well. We've been also, and then from that, so that's sort of like point of care to this massively multiplex types of tests that we could do to differentiate a lot of different viruses. And then we've also been doing genomic surveillance here in Massachusetts. We've seen that they're about, yeah, baby, I'll be there in a little bit. Sorry about that. They're about 30, I know, cutie cutes. I'll be right there. 30 introductions. Sorry. I'll be right there, sweetie. 30 introductions into the population, a number of super spreader events that we can really identify, including ones in a homeless shelter as well as in a health clinic. This really shows us how quickly these events can happen and how important it is to catch it, just as it emerges. And MassCPR is accelerating a number of different technologies. They are, ones that are point of care, massively multiplex ones, a number of ones for exposure testing, both from point of care all the way to massively high throughput, and these advanced sequencing technologies. And so it's a coalition of individuals developing these kinds of technologies across the grid. We then also need to connect that information in real time. We have been working in West Africa where we have sequencing, working in a number of hospitals and clinics that we're partnering with. We've created a system called Sentinel, which allows for lots of different points in the system, from citizen reporting to dashboard visualizations, contact tracing, and sample tracking, and also being able to bring in new diagnostics and capture them in a system in real time. This is just want to show you a couple of these kinds of tools that others are also developing, but the kinds that we're developing within Sentinel are things where you can do symptom reporting, pull in your contacts either automatically or you're self-reported, track your symptoms over time, and see what's happening in your contact network. And then visualizations to allow you to see what's happening on a global scale and what's happening on a local scale here at Harvard or around the world. And finally, empowering. So, we have these tools and technologies, but we need to make sure that frontline workers, first and foremost, are informed and know the best. So at Harvard University and at the Broad Institute, we've been doing work for a number of years, training, and now with our partners in Africa, we've trained 900 individuals, including from Southeast Asia, to do genomics, diagnostics of different kinds, and also bioinformatics. So giving lots of different trainings, deep courses, several month-long courses of daily work in this effort. And also we want to empower the children as well and citizens alike. We worked with the Sarasota Military Prep Academy. Over the last number of years, we developed a pandemic preemption curriculum that teaches them all of the different aspects of outbreak response and then has them act in a school-wide simulation. And several years ago, we started actually working on these mobile applications for contact tracing. We decided we also could turn those on their head and use it to create a virtual virus that spreads via Bluetooth on the children's phones so that they can actually have a virus that they are fighting and contending. And so the students have to actually respond to an outbreak in real time. And the great thing about that is you also are generating really rich epidemiological data that also takes in behavioral effects. And so this is actually data from an outbreak we spread in fall of 2019 before this virus jumped in Wuhan, China, but that was spreading a SARS-like virus with an R0 of 2 to 3 that spreads asymptomatically. And so we already have this interesting data showing this work. In essence, that's sort of the complete effort of Sentinel, and the kinds of efforts that we're doing here across the board at MassCPR is bringing these different kinds of technologies to bear. And MassCPR is really about building a community. Our diagnostic working group has about 150 clinicians, academics, public stakeholders, and we've had regular engagement with the Guangzhou Institute in China, and are very excited about this possibility of connecting with India as well. This is just most of the work I presented here is work from my lab. So I just want to acknowledge them and their holiday card from last year, which was wishing us all roaring 20s, which it has been, but not in the way we would have hoped. In any case, thank you so much. I think over to you, Dr. Reddy.
Thank you very much, Professor Sabeti. We now move on to a different dimension of diagnosis and surveillance with Dr. Michael Mina, who is an assistant professor of epidemiology at Harvard, T.H. Chan School of Public Health. He is also additionally assistant professor of immunology and infectious diseases at the Harvard School of Public Health. And he is also the Associate Medical Director in Clinical Microbiology at the Brigham and Women's Hospital. Michael's research combines mathematical and epidemiological models with high throughput phage display-based serological investigations. Over to you, Michael.
Great. Let me just hold this. Okay, so today I am going to be talking about different testing strategies and how we can use them for disease surveillance and control. And this will be a fairly high-level talk in terms of strategies and sort of showing a few results from some mathematical models that we build. So first, why do we need surveillance? On the left, these two graphs are the current cases as of yesterday for total cases of COVID-19, both cumulatively on the left and then daily new cases. So we can see, of course, and everyone's aware, that this virus is continuing to increase across the globe. And so surveillance and outbreak detection is one way that we're going to continue to defeat this virus everywhere it pops up. And we also know that this is a very seasonal virus. And so what you can see on these two graphs on the right is this is the seasonality of the virus since 2010 to 2020. We see that every October and November coronavirus, sorry, this is seasonal coronaviruses, they come back in the fall and lead to major outbreaks and lead to a lot of cases that usually aren't really discussed too much because they're usually just seasonal coronaviruses we haven't cared, but we anticipate that this particular virus will probably follow similar patterns as well. And so we should expect that anything we're seeing now, at least in the Northern Hemisphere, we might only get worse in the fall. So we certainly need to keep surveillance at front of mind. So there's a couple of different approaches, and I think you'll hear a little bit more after my talk about the specifics of virus testing. But there are two different types of tests that we focus on. One has been, and the one that has been most discussed globally has been the virus testing. This is the nasopharyngeal swab or the nasal swab, or even with saliva, and using molecular tools, which we just heard a bit about as well, to look for the virus. There's also antibody testing, which is usually the antibodies are often delayed by about a week or so before they become detectable within an individual after the virus has been detected. But the difference is that the virus is transient. It usually disappears after 1 to 3 weeks or so, whereas the antibodies will end up lasting as a signal of detection from about a week after symptom onset and then for months or potentially years afterwards. So it can be a very powerful tool for surveying large populations at any given time. And just to give a focus on why antibodies versus what these two might look like, right here I have two graphs on the left. If we think of each column of each of these as a week in time and each row as an individual, what you can see is that the virus positivity will come and go. Once it arises, it will usually disappear after a couple of weeks, whereas antibodies, they'll be shifted over to the right by about a week. But once they become present, they generally stay there. And so what we can see is if we were to be in the middle of an outbreak and not be testing a large number of people, we could actually even just miss whole infections altogether and just have no idea that there's an outbreak going on at any given time. Whereas with antibodies, we can usually detect the cumulative sensitivity to detect cases is really quite high. And so these both have their benefits and drawbacks, and I'm going to talk a little bit about what those are. So if we, currently we've been primarily focused, again, of course, on detecting the virus. And this is a toy model to show how serology or antibody testing can be used to better inform what's happening with virus positivity. If we go into a community and we find that there's 5% of people are positive for the virus at a given time, say in a nursing home, a school, or a city, we don't really know much more about the trajectory of that virus, except that 5% of the people are positive. However, if we add antibody testing to the mix, we can gain a lot of additional information. If we do antibody testing, we find that 55%, just as an example, of individuals have already been infected with this virus. Then if 5% of people are infected at a given time, then that probably means the virus is on it, the outbreak is on its way down in that community. If we find a very small number of people, like 6% are serologically antibody positive, and 5% are virus positive, then we can anticipate that this is an emerging outbreak in that community, and we might want to put a lot of PCR testing there and sort of take all precautions we can to try to keep the outbreak down. So these two aren't necessarily, it's not one or the other, PCR or antibody testing. They can really be used together for surveillance and outbreak mitigation. And in this case, I'm pointing out resource allocation. So what are some surveillance characteristics and trade-offs of those? Normally, when we're looking at surveillance testing, we can have either a highly sensitive test, we can have very fast tests that give you results within minutes, or we can have a low cost or a high frequency test that we could use every day, for example. It's extremely hard, however, to get all three of these into a single test. And so the highly sensitive test might be like a PCR test in the lab, but that, of course, doesn't always give you very fast results because the test has to go to a laboratory, and it can be more expensive. So the priority order that we normally pay attention to is oftentimes sensitivity comes first, and then everything kind of falls after that in terms of cost and frequency, and then the speed. But a fast test that is sensitive is often expensive, and we hope this might change, but at the moment they are expensive. So the question that I would pose is, what about a test that gives you very fast results, is inexpensive, that you could use daily, but is 100 times less sensitive? Would that actually be a useful test? And we aim to explore that question. And the way that we did it, and the reason we did it was because there are available tests, and you just heard about some of them, and they might actually be becoming more sensitive as well. But there are many tests that are antigen-based tests that can be very fast and very inexpensive, but generally are much less sensitive than PCR. So to really answer this, we can look at what the viral kinetics look like within a person. After a person gets infected, on the y-axis here, I have a virus concentration that you might detect on a swab. Once somebody gets infected, they usually have an incubation period of a few days before they become positive on a PCR test. But then once they become positive, the virus is essentially an exponential growth, and it will grow very quickly, and will often grow orders of magnitude within a given day. And so that means that the difference between a high sensitivity test, showing here on the lower horizontal line, and a lower sensitivity test, meaning you have to have more virus to detect it, is actually only, although it's 100-fold difference in terms of the virus detection, the time period that actually represents might be very short, might be less than a day even, between when the PCR test turns positive and then the low sensitivity test. And then the virus grows, and at that point it becomes transmissible before falling off again. And then you get this long tail where people are no longer transmissible, but the low sensitivity test does not detect it, the high sensitivity does. And so at this point, we might say that these be false negatives, but clinically they might not actually be false negatives. They might be that the person is no longer even transmitting, it's just dead virus that is being detected. So if we take this into account, can we try to understand if there's better strategies for the use of these tests? So we built a number of mathematical models, and I don't have the time to go into the models here, but I wanted to show just a couple of results. And one of them is to compare these two tests and what it would mean for the amount of infectiousness that we remove from the population. And so if we don't do any testing and we just wait until people become symptomatic and self-isolate, we don't really remove too much of the infectiousness from an individual's infection, and people will still primarily go on and infect. But if you do daily testing with either the high sensitivity or the low sensitivity, or even every 3-day testing, or really even every week testing, we can remove a tremendous amount of the infectivity from the population And it's the frequency here of testing that matters most, much more so than whether you're looking at a high sensitivity versus a low sensitivity test. If we map this total infectiousness removed onto what is the outbreak size that occurs, relative to not testing at all, we see that if you just test every day or every 3 days with a very low sensitivity test that might be able to be produced very cheaply, you'll pretty much essentially stop all outbreaks. Even weekly testing using will do a very good job at stopping most outbreaks. And you can do that almost as well with a low sensitivity test. So this points out that frequency more than sensitivity is really important. And this is taking the same group of data, but then adding one additional dimension, which is how many days does it take to get the result back? 0 would mean a result that you get back in minutes, like a rapid test. And then 1 and 2 are 1 day delay for results and 2 day delay for results. And what we can see is every day delayed has a huge detriment in terms of your ability to detect and stop outbreaks. So if we look at weekly testing here, both of the sensitivity tests can do a decent job, but if you delay the results just by a day or 2, you end up getting many more infections over the course of an outbreak. And of course, now in the US, we're seeing very long delays on the order of a week or more. So we're going to have increasing difficulty to stop outbreaks. And the last 2 slides I want to show is, can serological antibody testing also work? So those results were all about viral testing. But I had mentioned earlier that antibodies can come up and they can actually be powerful tools to detect infections as well. And so we looked at this, and this is just some of the results. And essentially each box here is showing if we were to test 5% of the population, 10% of the population, or 20% of the population on different intervals, would serological or antibody-based testing be able to perform well to capture and detect outbreaks? And what we find is actually if the lower the frequency of test, serological testing can actually perform better than virological testing to detect outbreaks early. And this is primarily a function of the fact that antibodies give you a cumulative incidence, and so the signal doesn't disappear if you're doing low frequency testing. If you get up to very high testing, they perform fairly well. But once you get up to daily testing of a large fraction of the population, PCR will ultimately win out by a bit. But these are just to show that antibody-based testing can actually be used as cheap alternatives to virus testing. And in fact, if we consider that antibody testing might be half the price, that means maybe we can test twice as many people. And so it turns out that if you do weekly testing, for example, with a virus of 5% of the population, it takes you longer to detect the first case, which is the y-axis here. I apologize for not describing that. It takes you longer to detect the first case than if you were to test 10% of the population serologically on a weekly basis. So serology shouldn't be discounted as a very powerful tool when you're testing over a very large population like a major city. So just to conclude, virus testing and serology testing can work very well together. I would suggest that instead of focusing so much on sensitivity of the assay, we should really place frequency and the speed to get results front and center. And serology can provide a very powerful tool for outbreak detection to either be used in conjunction with or even potentially in lieu of virus testing. So some of the contributors, Dan Larmore, Roy Parker, James Hay, Millen Tomei, and Brian Wilder at Colorado or Harvard helped to build some of the models. Thank you.
Thank you very much, Michael.
Absolutely.
India is just about to reach the 1 million mark today in terms of COVID-19 cases. So for us, the Indian experience becomes very vital in terms of not only learning from international experiences, but also telling the world what we are doing about it. We have Professor Lalit Dar, who is a professor of microbiology at the All India Institute of Medical Sciences, where he heads the virology section. His area of work extends to molecular biology and immunology. He is a member of the National Technical Task Force on COVID-19 of the Government of India. He is a technical consultant to the International Atomic Energy Agency and has been a Fogarty Fellow at the National Institutes of Health. Over to you, Professor Dar.
I think you're muted, Dr. Dar. Still, you need to unmute, please.
Yeah, thank you, Dr. Reddy. Thanks to Harvard and to the Public Health Foundation of India for inviting me for this session. I'll be speaking about the Indian perspective on the diagnostic testing as well as surveillance for SARS coronavirus 2. Sorry, I'm having some, okay. Yeah, so to start with the virus, of course, the intent is to just recapitulate the genes. The envelope gene is on the outside, and from that project the spikes, which is the S gene, the S antigen, and then you have the matrix and the membrane, and then the nucleocapsid. So all these, the ones which are important for diagnostics as well as for serology, are the for surveillance are the E gene, the product of the E gene, the S gene, the N gene, which is the nucleocapsid, and its product, and the ORF, which is the open reading frame 1A and 1B. So these are used in the genes are used in the diagnosis by real-time PCR, and the products are used for the antigen test as well as the antibody test to determine the seroprevalence, etc. If you look at the types of tests that are available for the diagnosis of COVID-19, we have the nucleic acid amplification tests, and we have the real-time. These are useful for the diagnosis of early acute cases. We have real-time reverse transcription polymerase chain reaction, or the RT-PCR, which can be available as either in-house, commercial, or near point-of-care tests. And then we have the isothermal amplification, the combination of RPA or LAMP with the CRISPR-based detection, which Dr. Sabeti has just been describing. The antigen detection tests are also available, and there is an immunochromatographic test which is available, which is based on lateral flow. And there are various commercial tests, and in India, recently we have validated and evaluated a test.
Lalit, can you go full? Lalit, can you go full screen? Your slides are not being fully seen. Can you please go full screen on the slides?
Sir, I am full screen as far as I can see. Sir, at my end it is full screen.
Dr. Dar, maybe Sue can project your slides for you, and you could just say next slide, and she'll move them forward.
Okay. So should I remove the share screen then? I'm so sorry.
Yeah, that's all right. We can remove it and let Sue project it. Then everyone will be able to see it clearer.
Okay. Yeah, we can move to the next slide, please, Sue. The next one. Yes, please. So we have evaluated the antigen test along with the Indian Council of Medical Research. One of the tests which we have evaluated is turning out to be useful because of, although the sensitivity is lesser than the real-time PCR, it still picks up in the range of high CTs. CTs below 30, it picks up about 75% of the cases. Then we have the antigen, the antibody test, and India has developed its own antibody test for detecting IgG, which is called COVID Kavach. It is developed by the National Institute of Virology, and this test is available for the serosurveillance in India. Next, please. So the advantages of RT-PCR are that it is considered, so far it is considered the gold standard. It has the highest sensitivity. It has a very low limit of detection, less than 10 copies per reaction, a high throughput, which is feasible except for the near point of care platforms, which have a lower throughput. And it has a reasonable turnaround time. We can give the report on the same day, mostly within a few hours. With the near point of care tests, you can do that within an hour or two. And there's a large variety of tests available commercially, which is, although it's an advantage, it can also sometimes be a bit of a disadvantage because though you have choice, the interpretation, etc., keeps varying between tests, and with the global availability and the situation being what it is, we have to keep on looking at new tests with their different systems of different combinations of genes and different ways of evaluating them. Next slide, please. So which test does one use for the real-time PCR? In India, we initially started in February, early in February, and we started with the in-house indigenous test developed by the National Institute of Virology, Pune. The National Institute of Virology is an institution under the Indian Council of Medical Research. The kit used basically the WHO-endorsed primers and probes, and these kits were then supplied to labs across the country, starting with 13 labs and then increasing to now a huge number of labs, which I'll be coming to, which are using kits supplied by the Indian Council of Medical Research, including the indigenous one. There are many commercial kits which are now available. There's the open, they are the open RT-PCR platforms, and again, the validation has been done in India again, and many of these are recommended for use. For the then there are the closed platforms for the real-time PCR, like the Abbott platform, the Roche platform, which can do a much larger throughput. And then we have the closed near point of care platforms, which are basically used where the workload may not be that high, but the report is required urgently. Next slide, please. Now, with the various primers and probes that have been used initially were based on the E genes, the E gene, the RDRP gene, and the ORF, the open reading frame 1AB, and along with the RNase-P gene as the internal control. Next slide, please. So the ICMR has approved a large number of kits already, including 26 indigenous kits which are produced in India. The limit of detection of these tests is, as you can see, it's extremely low. You can pick up less than 1 copy with the WHO primers and probes, and particularly for the E gene. And with the other commercial ones also, there are a couple of studies which have shown that they can pick up less than 10 copies on a regular basis, including the ones which are near point of care. Next, please. Next slide, please. So this is the data until at the beginning of this month. Now, of course, we have we have crossed the 10 million mark for the total amount of testing in India. These are the cases, but the interesting thing here is that the government has actually mobilized at least 764 laboratories at the beginning of the month, and many more since then, and 292 private laboratories, which are basically chains of laboratories. Many of them are chains, so they have branches across the country. So we have a huge number of laboratories now functioning across the country, and it is a big country, so any number that we have still continues to seem less. Next, please. So what sample do we take? We in India are using for the real-time PCR the nasal swab combined with a throat swab in a common viral transport medium. And the alternative of the lysis buffer is also used in certain situations. Nasopharyngeal swabs are an option, but they are a little more difficult to get. The sputum samples are useful for the latter part when when the patient is already into severe infection, respiration, it's gone into the lower respiratory tract, then you need sputum samples because you can't pick it up from the upper respiratory tract much of the time. Then the endotracheal aspirates in those who are intubated, or the bronchoalveolar lavage to get a lower respiratory tract sample. Saliva has also been tried, and feces in another sample where the virus can be detected, although it's not used for diagnostic purposes. Next slide, please. So when do we test? It is for diagnosis, it's important to test early in infection because as we know, the pattern of virus shedding is like influenza and not like the first SARS virus. It can be picked up about 3 days before the onset of symptoms and can go on for a longer period of time, depending on the kind of shedding that is happening. It normally live virus stops shedding around 8 days, but you can still continue to detect virus by the RNA by PCR until a median of 20 days. Next slide, please. Who do we test? So in India, we are testing those who are suspected acute cases of COVID. We are also screening contacts of positive cases so that we can test, trace, and isolate these people. We have been doing a lot of screening in the early stages. We started around 2nd of February, and between that period until the lockdown on March 24th, which was subsequently opened some time back, the evacuees were screened, which were brought in from China, Japan, Iran, and Italy, and we were part of this testing. Migrants who move between states because the place of work was under lockdown, and due to various difficulties in terms of facilities, etc., they'd like to move back home. So these migrants are screened. And then we have discharge and release from quarantine, which used to be there earlier as testing was necessary. But now that we know that there is no virus on day 9, we have stopped using that as the discharge criterion, just like other countries. And then, of course, we use this test, the real-time PCR, as a validation for the test. Next slide, please. And these are the various categories of the people who are tested in India as defined by the Indian Council of Medical Research. Next slide. How do we test? We have to take all precautions. Personal protective equipment has to be there. The samples have to come in triple layer packs. Biohazard hazard labels have to be there on it. We use BSL-2 precautions. In a biosafety cabinet, the sample is handled in a biosafety cabinet class 2 with full PPE. And there are various guidelines for disinfection as well as waste disposal. There are Government of India rules which have to be followed. So it is a fairly cumbersome setup that is required. All these facilities are required for testing. Next, please. Next slide. Yeah. So and then we have to disseminate the report to various agencies, and that is where the data gets collated eventually between the Integrated Disease Surveillance Program and the Indian Council of Medical Research, apart from giving the report to the patient and the treating physician. Next slide, please. So the quality assurance, we ensure by kit internal controls, both positive and negative controls, sample internal controls, which are basically the housekeeping genes, which are run through the whole process, and the RNA-sp or the beta globin genes, etc. And the external quality assurance, there's a program of the Indian Council of Medical Research, where samples are sent from the lab, once they test, as well as a panel is also being now planned for being provided to the labs. We also have an accreditation body in India which is accrediting many of these labs for testing. Next slide, please. The limitations of real-time PCR. This is the last thing. We need a biosafe and biosecure laboratory setup, as we've said. Trained and experienced staff is required, expensive equipment and consumables. It needs expertise in techniques and interpretation. Turnaround time is at least 5 to 6 hours, except for the near POC platforms. And the last is that there's a challenging variety of kits with different parameters. The gene targets vary, formats vary. There may be single well or 2 wells or 3 wells per sample may be required in the plate. They may be monoplex or multiplex. The controls, some of them have housekeeping gene controls. Others have process controls only, which is an internal control which is added but does not test for the quality of the sample. It tests only for the process of extraction and the test itself. And then they have different cutoffs and interpretative criteria. Some of them you need CT values, and others you need to actually look at the curves in detail to see whether they are sigmoid or not. So it has been a learning experience, and real-time PCR has been fairly challenging to implement even for diagnostic purposes, but a lot of labs are now doing it very efficiently. Next, please. So I would like to thank you and the Indian Journal of Medical Research. We have some publications there. A lot of data from India is available, and it's a free online journal. And for more information, you can take a look at that. And this is my institute. My whole team in virology has been helping out with this. Thank you so much.
Thank you very much, Lalit. Any comments or questions can be posted on the chat box, and we'll try and address as many of them as possible. Before those questions come in, may I ask the experience both in the US and in India of pool testing? How often is this being employed, and what are the potential advantages and disadvantages?
Yep, I can take that, and I think maybe Michael and I might tag team that a little bit. I think he'll be able to speak to a lot of the models of how well it would work. And in principle, it's one of these things that would be terrific to do, but in practice, it's a little more challenging for a few different reasons. One is from the sensitivity standpoint, although Michael made that great point that sensitivity is not as important as long as you can do rapid turnaround testing. So that, that sensitivity is an issue, but not as much of one given what Michael and others are seeing. And it can be improved even more from a sensitivity standpoint. If you think about doing your testing of pooling, I describe it as pooling people. If you if you actually pool people who are, like, if you pool test people who are already in close proximity with each other, like pooling an entire family or pooling an entire workforce, it's people where if an infection was to happen in one, might happen in multiple. So even if your sensitivity to identify one individual in a group of 10 might be lower, if there were 2 or 3, it would be higher. And so pooling in groups is a good way to do it. That way, it also means if you quarantine people, you sort of quarantine them together until you take the pool apart and figure out who's actually positive. Those are born from conversations with Mike Springer. But on the other side of it, though, beyond sensitivity, it's actually just a practicality. When we talk to the Broad Institute where I work about it, they just, a lot of the challenges is upstream of just how do you get all those samples in together? How do you concentrate it so that you get the right level? There's just a lot of practicalities on what it looks like when you actually pool the sample and then concentrate to identify what's going on. We have done it in the past. My lab has done it in the past when we pooled hundreds of clinical samples where we're doing metagenomic sequencing. It can work, but it actually practically does add a lot of upstream steps sometimes. So that's what people are working on, to get it to the point where it's practically possible. Michael, do you want to add to that?
Yeah, I would just to add that there are ways to do it. I fully 100% agree with it's always the pre-analytical steps, the pieces that come up front of the actual test that are almost always the bottlenecks with clinical testing and surveillance testing. But there are a few additional tricks or changes that can be made. If you didn't want to lose sensitivity, for example, you can actually pool tests in a way with the primary sample so that you can actually even boost signals and sensitivity. The problem there is if you then get a positive pool, for example, if you take your swabs and put 10 swabs directly into a single reaction without diluting them first, you can boost the sensitivity. But what it means is that if you get a positive, then you actually have to go back and re-swab those individuals because you have made a primary specimen. So it can be very powerful, but these come with some trade-offs. But that's also where, as Pardis said, you can potentially cohort in such a way and group them so that you're pooling people who are likely to have transmitted to each other. So then it makes sense if you need to ask them all to quarantine and to re-swabs, that can be useful.
Okay, there is a follow-up question on that. Does it mean that pool testing works when the pretest probability is more?
Yes, I would say that that it would work in both cases. I mean, it should work. These tests are very, very sensitive. So the pretest probability will give you a better predictive value, for example. But I think that that they should work. What can maybe the question is originating from the idea that if you have too high of a prevalence in the population, pooled testing can become less efficient. If, for example, every pool is turning out to be positive, and it starts to lose efficiency. We've done some exploration of where those thresholds are in terms of what prevalence you can get up to before you start becoming less efficient in pool testing. And so depending on the size of the pools you're going to be producing, you have to have, with increasing size of your pools, you need to have increasing prevalence to make it worthwhile.
There is a question from an Indian official who is in charge of a district. For a district where there is no local or community transmission as of now, what would be the best way forward in terms of testing so that the situation remains the same even after several months in terms of surveillance for control measures? Lalit, would you like to take it? And then maybe Mina can, Dr. Mina can answer as well. Lalit, would you like to answer that question?
Yeah. Sir, I was actually wanting to mention a little bit about the pool testing before I go on to this one. So pool testing, actually we tried in our lab. The Indian Council of Medical Research actually recommended just small pools of 5 each for about when the prevalence is around 2%. But what we are seeing now is that it doesn't work practically for us because our positivity has gone up much higher than that. In Delhi, we even touched at one point of time about 30 to 40% positivity. So pooling didn't work because practically every pool had to be repeated. So, can we have that question again, sir, if you don't mind?
Basically, the question that was being asked is, right now there is a district with very no evidence of no transmission.
Right.
But how do you actually keep it that way in a surveillance system? What kind of testing strategy should be used?
I think I think Michael has already defined those testing strategies rather well. The purpose right now in India, because we have an antibody test and most of the surveillance is being done by antibody tests along with the viral testing for this as per the criteria. We need to combine both these things and keep them running and then collate the data after that. And also the antibody tests would have to be covering a sort of significant percentage of the population to give us meaningful results. So I think a combination of both viral testing and antibody testing would work. Unless, of course, we have a solution like the one which Dr. Sabeti mentioned, which can perhaps do things at on a much larger sort of scale and get those kind of correlations within the population.
How long does the antibody last? That's another question.
That's a good question, sir. As of now, we don't really know. We know that it takes a little time to come up. It's not as soon as one would expect with other illnesses, at least in India, whatever we have seen so far. It's somewhere around 2 to 3 weeks for the IgG to come up. The IgM tests, unfortunately, are very erratic, the ones we've validated in India so far. But the IgG comes up in about 3 weeks. But how long it lasts is anybody's guess as of now. I don't know if the other speakers can answer that.
We found that the antibodies often, in our hands, we've found that they come up about 10 days after symptom onset and to 14 days or so. Sensitivity becomes very, very high by 2 weeks. And then they tend to be lasting on the order of a couple of months to much longer. But some people are certainly waning and their antibodies are potentially even reverting back to what looks like a seronegative status within a couple of months for some individuals. And then others, particularly those who have more severe infections, sometimes can then persist for quite a bit.
Michael, does that have implications for vaccine development or herd immunity? That the antibody levels seem to be plummeting in about 3 months?
Well, we're not quite sure. So I would suggest that the antibody levels plummeting and waning, I think, is actually just it's a feature not that's necessarily distinct to this virus, but it's really a feature that's distinct to having primary infections. Most people are getting this infection for their first time, so they haven't yet pushed a lot of these cells into their bone marrow. It may well have some implications for vaccines and durable immunity, insofar as, like many vaccines, people will have to be boosted, and that's a very normal feature of vaccination programs as well.
There's a question on which gene has the highest sensitivity.
For antibody testing, so that question arises a lot for the antibodies, but it could be for both. For antibodies, it seems to be sometimes looking for antibodies against N or nucleocapsid has been potentially a more sensitive measure, but potentially less meaningful immunologically than the receptor binding domain or the spike. But maybe Pardis or Lalit can talk more about if they have any data on the exact genes for PCR.
Yeah. Oops. Let me just see. So for us, like I think the most people are looking at region within the sort of open reading frame 1 is a common thing. A lot of times for sensitivity and specificity of genomic tests, it's the most important thing is really just the conservation of the sequence to make sure there's no mutations in the guide. When you're doing molecular-based tests, it's really making sure that the connection between the guides that you're trying to target and the sequence of the virus remains intact. So when we think about that, we think about places where there is a lot of stability of that region. It's not quickly mutating. And there's sort of other features of the actual nucleotide sequence that matters. So in this particular case, we used ORF1A, and a lot of people do the same. And some of the different kinds of guides have multiple targets where they're looking at 1 or 2 targets, or sometimes even 3 targets in the virus to increase sensitivity.
There's a lot of discussion now. Go ahead, Lalit. Go ahead.
Yeah, I was just mentioning that what we've seen is that with the WHO primers, which target the E gene, the RDRP gene, and the ORF gene, somehow they are better optimized for the E gene. So what happens is that the E gene tends to be positive in a larger percentage of cases, whereas the other 2 turn out to be negative for real-time PCR. And there are some studies which have shown that it's just a matter of optimization of the PCR, really.
Okay, there's a question that's bothering a lot of people now that they're opening up. What is the role of regular screening of all students or employees, students in an educational institution or employees in an office as they're reopening? Is it practical to screen, and how repetitively should the screening be done, and what's the best strategy for that?
So I have strong opinions on this. Michael might be more expert, but I'm more of a, yes. Michael, do you want to take it, and then I can put in my little?
Well, I would just say that I think it's entirely related to the resources that are available. In many ways, if you have a university setting or a closed setting like a business or company, I think that a lot of people are thinking along the lines of very frequent testing. I would say, practically speaking, there might be more efficient ways, at least as we look at the long term, to really be able to test, where we slow down the frequency of testing. We maybe follow a fraction of the people over time who are very willing and sort of eager participants. And then if outbreaks are detected, you have some sort of adaptive strategy to to start spinning up testing and do it more frequently for short bursts of time in order to kind of keep, just from a very practical perspective, where people I think will get burned out after a while if we're going to be dealing with this for potentially a year or more.
Yeah, and I would just add to that. I think that was a great answer, and I think that fundamentally, it's great to be able to do that. And here at Harvard University, we're having conversations about being able to do that. And I think it's nice, although it's sort of hard to kind of contend with when you see that so many people who are symptomatic can't be tested, and we have such limitations in testing to do that kind of testing. It actually goes back to one of the other questions that Dr. Reddy noted from the group about what do you do if you're in a community and you don't have any infection? How would you think about this? And in my mind, it's sort of if you have a community in a close community, in particular if it's like a college or residential college, and there's nothing in the community at the time, then all of your testing, you're going to do weeks and weeks of testing that are all going to be negative or 0.01% positive. And so that's a lot of wasted testing, and you have to think about your long-term strategy. And in my mind, I think about your degrees of contact. That essentially, if in thinking about the Harvard University campus, if you want to keep it safe, you need to know if your staff's family are healthy, if your students' contacts, if they go to a church, if they're healthy. You have to actually be looking. We need to have a perspective of what's going on around it. And so that idea of the Sentinel that we've created is that kind of view. Like one of our apps is called the Lookout, but it is about looking out like to the next degree and the next degree. So for your town, you really want to be able to making sure that you can do observation and testing of the nearby towns, and that's how you'll keep your own town safe. And for the college as well, and the school, it's making sure that the families of your students are healthy and safe, making sure that the people that they work with are also healthy and safe. So that's why we think that using mobile applications to quickly detect symptomatic individuals and then pointed testing at the individuals who are positive is a better strategy over the long term. In the short term, it might allow people to immediately start coming back, but in the long term, we won't be able to stop these sparks from flashing. And I'd just say our genomic sequencing data that we have released one set of and are releasing another set right now will essentially show that when these sparks happen, it's a day. So by the time you actually detect it on your campus, if there's one event in which multiple people got together, this virus will probably be throughout your campus. And so the cat's out of the bag when it's come to your shore. You have to catch it well before.
Okay, there's a question whether we should be testing symptomatic patients in a pool.
Symptomatic patients in a pool doesn't make as much, like from that perspective, that's the one where I think that's what Dr. Dar is talking about, where if you're getting 30% positivity, it's because you're probably testing a lot of symptomatic individuals as well. And at that point, you'll have to basically untangle that each time anyway. And so if it is symptomatic and it's likely COVID is the symptomatic cause, if that's the main thing circulating, then when you pool, you're always going to have to end up separating it. So I think that pooling makes more sense for asymptomatic or when just COVID in general is very low.
Michael, there's a question on whether there is a possibility of detecting false positives with antigen tests because of dead viruses, just as in the case of RT-PCR.
Absolutely. I think that it's certainly possible. I think that probably in the long term you'd get more, if we think of detecting dead virus and after somebody's transmissible, I mean, it's a bit of a gray zone to say whether the virus is completely, if there's no viable virus left or maybe some, but I would say that the antigen tests probably have a lower risk of remaining positive for longer after somebody is no longer able to have viable virus in them or transmitting, versus the PCR will probably last quite a bit longer. We see, for example, that PCR can remain positive for weeks, if not months in some individuals, whereas there hasn't been much evidence that I've seen that the antigen test remains positive for such a long period of time. And I would say that I think that that's a very important piece to this. Normally people are looking at an RT-PCR test positive when the antigen test is negative and saying that that's a loss in sensitivity of the assay. But I think potentially more importantly, it's usually on the downslope when people have cleared the infection. And there's an argument that could be made that suggests that real-time PCR remaining positive for 6 weeks or 8 weeks could be, that could be considered clinical false positives.
There's a question whether asymptomatic persons can transmit onwards.
Lalit, you were muted a moment ago. Did you want to answer that? Sorry.
Yeah, no, I was actually referring to the previous one. The antigen test, I think, has some advantages in terms of. I agree that you will not pick up the ones who are not infectious really, Because what happens is that when we reach CT values of above 30, which is when these people start becoming less infectious, and now I think there is some evidence that at CT values in the real-time PCR of about 33, people are usually not likely to be infective. And the antigen test doesn't actually pick up those. So it's picking up about 75 to 80% at CTs below 30, which is what I mentioned. So it's probably picking up the ones who are likely to be infectious. And I think that is very useful. And if we combine it with what you mentioned about doing testing repeatedly, I think that would be a good option from what we've seen. What was the next question, sir, again?
Basically, that question was, do asymptomatic persons transmit onwards? What is the risk of infection from asymptomatic people?
That's again, I mean, the jury is still out on that to an extent, but they do carry the same amount of virus is what we have seen. I mean, in terms of course, CT is not the best way to look at the viral load, but it definitely we've seen the same amount of CT values, the same type of CT values in people who are totally asymptomatic. And we had the opportunity to follow a cohort of Italians who in the initial phases who turned positive here, and they were asymptomatic, many of them. 9, I think, out of about a dozen of them were asymptomatic, all through, but they had the same amount of virus. So, but they don't cough and they don't sneeze. So then the chances of actually spreading it may practically be less. But I'd like to hear from our Harvard colleagues.
Yeah, I agree. I think that certainly that's one of the burning questions of this pandemic has been what are the role of asymptomatics in transmission. And I would say that it's very likely that asymptomatics are transmitting, and it would be hard to get the type of transmission dynamics and population dynamics and spread that we've seen if asymptomatics are not spreading the virus to some degree. So I think that it's very likely they are.
So we have 2 questions that after which we'll close. One is, do we have conclusive evidence of reinfection of people who recover?
I think that there's always going to be the fringes of the distribution. You're going to have some people who, I know just here in Boston, there are numbers of people who have been reinfected that have been in touch. And so we know that it can happen, but I think we have to, this isn't surprising. This happens with any infection in a small number of people, especially when you have the type of spread that we've been seeing as a result of this epidemic. So I just caution, I would say yes, but I caution people to not read too much into small numbers of cases and assume that on an aggregate level, we will probably, most people will be protected to some degree afterwards.
Okay, the last question is, does screening of all healthcare professionals help, given the fact that healthcare providers who are in frequent contact with patients have a high risk of infection? Should they all be screened routinely? And if so, with what frequency and by what method?
So we have been doing the screening of healthcare workers at AIIMS. Our experience is interesting in the sense that we saw that the healthcare workers seem to be acquiring infection from outside rather than from the hospital itself. Those who are working in the COVID areas or the high-risk areas with the COVID patients or even in my own lab for testing, I think were using enough personal protective equipment, and they were not the ones who were getting infected. We have been seeing that it is mainly those who are not working in the COVID areas are either bringing the infection from home or the community. So, so really speaking, the screening is useful more for the morale of the healthcare workers because they do, because it needs to be reinforced from time to time that they are actually well protected when they are following all precautions.
So what kind of screening test would you like to employ there?
We have been using real-time PCR because some of them are symptomatic, then the contacts of those also need to be tested. So we would get some positives, then all their contacts which were asymptomatic would also get tested. So it was just like Dr. Sabeti said that the best way possibly to screen in a population which doesn't have a very high number of infections is to look at the symptomatics first and then do the contact tracing and quickly check on the asymptomatic ones within the median incubation period or maybe a little later than that.
Michael, would you like to add anything?
No, I agree with that. I think I don't have much more to add to that.
Okay, we are still getting some questions, but recognizing that all of you have commitments at Harvard, and we had originally planned this for an hour, we have extended it a bit. I'd like to close this by saying that there will be follow-up sessions on diagnostics later on, based on the interest that has been expressed by the various people who have registered for this and participated in this webinar. And we'll follow it up with the Harvard group as to how best we can advance this discussion further. There will be another webinar on treatment on the 21st. And then thereafter, we'll have further seminars as well, exploring some of the issues. Since the COVID virus seems to be refusing to go away, I'm sure there'll be scientific developments that will be worth reporting on and discussing, even as we try to bring the virus to heel. So thank you very much for all of you who have registered. I'd like to thank the colleagues from Harvard University who have been very proactive in initiating this contact and connection and ensuring that some of their star speakers are available for this webinar. I thank the All India Institute of Medical Sciences likewise for coming in and participating in this webinar. And we'll have the director of the All India Institute of Medical Sciences on the next webinar as well. So both from Harvard as well as from All India Institute, we have star speakers, and the Public Health Foundation of India is quite privileged to have been associated with this. I must say that when I first heard of MassCPR, as a cardiologist, I jumped up and said, what is all this cardiopulmonary resuscitation at a mass level? Now, of course, I know it is Massachusetts Consortium on Pathogen Readiness. I've learned a lot besides the expansion of that term from this webinar. So thank you very much, dear friends from Harvard and from the All India Institute of Medical Sciences. And I thank all the webinar participants for their interest and for posing very stimulating questions. Thank you very much.
Thank you.
Thank you.
Thank you, Dr. Reddy.